tell you so many stories about him. I could tell you about the time he took his first sabbatical, and the division got together and presented him with a complete outfit of clothes from underwear up, because he looked like a bagman. We couldn't see him going to Paris just that way. And we had a dinner at Peter Luger's, and we presented everything: shoes, socks, shirt, tie, raincoat. And David was overwhelmed and stood up on the table, took off all his clothes and put on new ones. He was just a remarkable guy. He was a unique thinker. He always looked at things from a different point of view, and we need that in this. On a personal basis, he was giving and forgiving. But David Kaplan wasn't just generous. He was sui generis.
Next we'll hear from Dr. Ann Leland, who has recently joined the Division of Rheumatology.
Good afternoon. Because both David and I began our careers in areas related to human genetics, Alan asked me to discuss his earliest research pursuits as reflected in a series of publications. And let me go ahead and use the slide. David's first publication was entitled Aging of Human Cartilage, and it appeared in Nature on May 2nd, 1959. At that time, he was a United States Public Health Service trainee. In this and several subsequent papers, David and his collaborators characterized cartilage biochemically by studying the mucopolysaccharides of cartilaginous tissue. He found that normal aging of human cartilage involved changes in the relative abundance of the various mucopolysaccharide fractions, and proposed that the aging of human cartilage is a process of differentiation rather than degradation as previously thought. And this was the premise of his first paper. Two years later, in 1961, David co-authored a paper entitled Effective Acid Mucopolysaccharides on Hair Growth in the Rabbit. Based on the observation that children with Hurler syndrome have thick hair that seems to grow fast, he and his colleagues gave intradermal injections of mucopolysaccharides to rabbits and found that these injections initiated a hair growth cycle. If this area of investigation had continued, just think of the prospects for treating baldness in the pre-minoxidil era. Later, in the 1960s, David collaborated with Dr. Victor McCusick, a true great in human genetics. In a paper entitled The Genetic Mucopolysaccharidoses, published in Medicine in 1965, Dr. McCusick relied on David's biochemical methods to help classify the human mucopolysaccharidoses. In 1969, David published a paper in the American Journal of Medicine in which he classified the mucopolysaccharide doses based on the pattern of mucopolysaccharides in the urine. Another collaboration that caught my eye was that with Dr. Bruno Volk, a pathologist at the Jewish Chronic Disease Hospital of Brooklyn, who contributed substantially to our knowledge of Tay-Sachs disease. I was delighted to learn of their collaboration because Bruno was a lifelong friend of my father's dating back to the 1930s in Vienna. Each of the papers I read was concise and creative, with conclusions that looked towards the future. While reading them, I got to know David a little better. I will remember David as my fourth-year medical school dean, my colleague, a gentleman and a scholar. Thank you.
I'd like to continue with a bit more of David's career. One of the most important qualities of a successful teacher is the ability to serve as a mentor. David Kaplan's success in that role was unsurpassed. He generously and creatively supported the research of more than 2 decades of rheumatology fellows and junior attendings, always promoting their careers and achievements without a thought to first advancing his own. I will always remember how David influenced the beginning of my career in clinical research. Shortly after the start of my rheumatology fellowship, he handed me a piece of paper with an abstract he had typed within hand-drawn borders. It concerned his impression of the division's long-term experience with Imuran in SLE. He had supplied hypothetical data and drawn conclusions. His suggestion to me was, why don't you collect the real data and see if this holds up? This launched my interest in the clinical course of SLE and resulted in my first presentation at the American Rheumatism Association, and a publication for which our division has become well known. One conclusion from this early study was that maintenance therapy with Imuran, or azathioprine, an immunosuppressive drug previously used mainly to treat cancer, significantly prolonged survival in patients with severe lupus renal disease. We also found that maintenance Imuran was steroid-sparing and prevented lupus flares. Evidence for this can be seen in the data regarding hospitalizations among patients with initially mild disease, which were significantly more frequent among patients not receiving this drug. Despite fears that such an immunosuppressive agent might increase susceptibility to infection, we were also able to refute this concept. A successful researcher needs to be an original thinker, and David certainly qualified there. At the same time, however, he had a very strong ethical sense, always wanting to be sure that patients were not put in undue jeopardy as new regimens were tested. A perfect example of his ability to meld these two qualities was his design of another clinical trial of immunosuppressive agents in lupus nephritis. Studies in the NZBW mouse model of lupus had shown that a combination of Imuran, Cytoxan, and prednisone, each in low dose, was more effective and less toxic than conventional high doses of prednisone plus Imuran. We wanted to test this regimen in patients, but were concerned that a scientifically rigorous, blinded, long-term trial might commit patients to a regimen that was not optimal for any individual patient. It was David's suggestion to employ a crossover design with defined treatment periods. At the end of each period, therapeutic efficacy would be determined. Only patients who had not achieved the designated efficacy or who had developed toxicity would be crossed to the alternate regimen. If one regimen were clearly superior to another, most patients should be receiving it by the end of the study. This unique design would, however, ensure that a patient responding to an otherwise less successful regimen could continue to receive it. In our unfortunately small study, we found essentially no difference in efficacy or overall frequency of toxicity of the two regimens. However, Cytoxan was associated with unique and potentially life-threatening complications. Despite the small nature of this study, this data, I believe, was instrumental in most clinicians avoiding this regimen subsequently. To go on with an overview of David's research, I'd like to call on Dr. Joe Feldman from the Department of Preventive Medicine, who had the unique opportunity to collaborate with David.
I've been asked to speak about a side of David that may not be well known to most, and that's David as a clinical epidemiologist. David had an unusual insight to interpreting numerical data and an unusual facility to translate clinical phenomena into empirical terms. David and I worked on several projects, such as defining excess risk of cardiovascular disease in the mothers of patients of rheumatoid arthritis, examining trends of rheumatoid arthritis in Brooklyn, examining the effect of multiple paternities on outcomes, pregnancy outcomes of patients with systemic lupus, looking at the relationships between arthritis, hypertension, and nephritis in patients with systemic lupus. A typical collaboration with David would begin with a telephone call in which he would ask me if I had some time to look over some data with him. And when I agreed, he'd set a time, and invariably he'd come with a series of 3 or 4 sheets of paper with numbers that were written across and down and around. And we would sit down, and he would elaborate a series of detailed hypotheses that would fit in with the data. And in the process of elaborating these hypotheses, he would go over the biology and immunology of the hypotheses in a way that someone like myself without formal training could understand it. And after discussing the data, he would give me a few weeks to analyze the data, and I would analyze the data using fairly complicated statistical designs with multivariate models and covariates and adjusting and weighting. And 9 out of 10 times, I would come out with the same result that he had brought to me at the initial meeting. And so I developed